scientific evidence and also the clinical applicability of the guidance. So over to Claudia. Thank you.
Thanks, Jan, for introducing you, ladies and gentlemen. So the clinical scientific evidence was shown by Andrew and Jan, and as they told, we have had a sort of systematic research by the Cochrane anesthesia, and we had trials published between 1950 and 2009. There were several abstracts, new studies, and we used the science score to grade it and the level of evidence and the grade of recommendation. The SIGN guidelines have a big advantage to use. They are updated regularly, takes into account any changes in methodology. Explicit methodology is based on the three core principles: the development by a multidisciplinary representative group. That's very important, that people who are involved in a guideline are all included in this development. Systematic review that was done, and the recommendations are explicitly linked to the supporting evidence. That means evidence, not eminence. So the SIGN guideline has a developer's handbook, and I marked it green and orange. And the point is, we are in the green area right now with the development of this guideline. And the other thing is up to you to make a decision whether you can use it or not, whether you can introduce it in your clinical routine, and the group needs feedback from you whether this is appropriate or not. And the point is, first we had this organization, selection of guideline topic involving patients and their representatives. This is something you could do as well in your hospital, in your environment, in your local society. We had this development group. It's also good if we get feedback. We had the systematic review. We had the forming guideline recommendations, and there where we stand now. And the consultation and peer review, this is not done yet, and this is something we can consider in our society here, to think about having peer reviews. This is something, for example, in my country, they started with peer reviews in the ICU. That's also by the Physicians' Chamber introduced now. And I think there's a lot of countries like the Dutch colleagues who have that, and maybe we can use these systems to get peer reviews on these guidelines. And presentation and dissemination, this is also very important. This cannot be done by the European Society of Anesthesiology alone. This needs to be done by the national societies as well, and also by each of them. And implementation, this is something that's yet missing in our guideline, and this is something we need to put a much emphasis on that. And this is the key evidence. That's what already said by Andrew, and the grades of recommendation. The important thing why I'm showing this is that the grade of recommendation can be different from the level of evidence. For example, I'll give you one example. If you give a muscle relaxant before giving hypnotics, this can never be introduced in a clinical study because nobody really could do research on that. So if it's consensus, and that means consensus, a strong consensus, then you can grade up your level of the level of evidence, giving a higher grade of recommendation. So I want to focus on the fluids, and I think this is a lot of discussion we can have on that. And the ESA guideline says that people are encouraged to drink clear fluids up to 2 hours preoperatively, as Jan said already. And the point is why I'm showing this is that this again, because Jan already showed this, is that it took from 1981 till now to get evidence into practice. That's a long, long way. It's 30 years, and we know that for 30 years. And now we have guidelines to change behavior. Because why I'm saying that, it's because we are so stick to our safety rules that sometimes, and this is important, quite important, but this is also difficult to change behavior. And looking on the postoperative resumption, drinking is very important. Drinking as soon as the patient wishes after elective surgery. This is also not so easy to introduce that in your recovery room. That means you cannot do that alone. You need the nurses to get that implemented. And so it's important that you define how you can get that implemented in your recovery room. And the morbidity of immediate postoperative feeding was discussed here, and there was no systematic prophylaxis in these patients, and only 7% compared to normally 1/5 of your patients who have postoperative nausea and vomiting within the first 24 hours. I think it's a very low rate, and there was no aspiration. Looking on the early feeding, that means eating early after surgery versus traditional, so people cannot really, are not allowed to eat for a long period. That shows that usually you have a low infection rate in these patients. Using all infections, vomiting is a little bit increased if you eat very early. So this is something you can consider. And I think it's very important because the surgical colleagues changed behavior within the last years. The Scandinavian colleagues in the European countries were quite ahead of this policy, and they changed it very early. And as you can see here, I want to focus now on the less than 6 hour fast or clear fluids. And this is a recommendation to 4 hours. Half of them have introduced that already in 1996. So they are far beyond us. So 4 to 6 hours was 19%, and this is also very good. Less than 2 hours was allowed in 8%. That's also not so easy because you have some extreme attitudes in this situation, or it needs to put under these safety regulations, so it's up to you to make a decision on that. They have a less than 6 hour fast of like Brexit, 31%, specific guidelines for children, 76%, and so on. So in my country, they changed it in a national consensus, and it's very important that after European guideline, you also implement that in your country. And this is the result, the changing of this liberalized preoperative fasting routine changed in 2004, and now most of the colleagues changed behavior within the next 3 years. This is a lot of work, of implementation work that need to be done in this situation. And the new one was this 2 hour fast. The East one was 2 to 8 hours, and this was the standard, that means nothing after midnight. And you can see here that nearly 80% changed behavior. If you reach 70% with quality assurance methods, usually you achieve quite a good quality. So I want to go with you to identify the obstacles to change in these situations, and there are formulas of change. And either you reduce the cost of change to individuals and groups, that means make it very easy, getting much more out of it, that means having an immediate success. You can see then the cost of change is less. So that means that usually you don't need to put much input in that changing process. Usually, however, you have to put some energy in that, and that means you need either be dissatisfied with the status quo. That's times the vision of a new model for managing or organizing, or times the planned process for managing change. And all of these items has to be fulfilled. And then the change energy is more than staying on the traditional situation.